of a series of webinars focused on behavioral health provided through a collaboration between the Pennsylvania Medical Home Initiative, a program of the PA chapter of the American Academy of Pediatrics, and funded by the Pennsylvania Department of Health and the Children's TIPS program, which is a telephonic psychiatric consultation service program at Children's Hospital of Pittsburgh and funded by the Pennsylvania Department of Human Services. This webinar series aims to address commonplace yet challenging behavioral health issues presenting in primary care practice. This presentation is the second in this behavioral health series and is focused on advanced ADHD stimulant and alternatives in pediatric primary care. I am Renee Churchy, a pediatrician at St. Christopher's Hospital for Children and medical director of the Pennsylvania Medical Home Initiative. This webinar is recorded. The recording is available on both the PA Medical Home Initiative and Children's TIPS websites and will be posted on the University of Pittsburgh Internet-Based Studies in Education and Research ISCR website. For CME purposes, please be advised that both Dr. Schlesinger and I have no disclosures. Please note that the information presented in this webinar is educational in nature and does not necessarily represent the views or policies of the PA chapter of the American Academy of Pediatrics or their funders. Now allow me to introduce Dr. Schlesinger. Abigail Schlesinger, MD, is a child and adolescent psychiatrist with an interest in increasing access to quality behavioral health and developmental services for children and families. She was instrumental in the development of Children's Community Pediatrics Behavioral Health, CCPBH, a service that embeds therapists and psychiatrists in pediatric primary care. CCPBHS has won local, state, and national awards for efficiently improving access to care. Dr. Schlesinger has been appointed Clinical Director, Community-Based Services, Behavioral Science Division, Children's Hospital of Pittsburgh, and is leading the integration of developmental, behavioral, and community resources. She is the Medical Director of Ambulatory Integrated Behavioral Health for WIPIC, and is the Medical Director of Children's TIPS Telephonic Psychiatric Consultation Service Program at the Children's Hospital of Pittsburgh at UPMC. We are delighted to have Dr. Schlesinger present on this timely and important topic for primary care clinicians. Dr. Schlesinger, please begin your presentation.
Thank you, Dr. Turchi. In the next hour, we're going to focus on advanced ADHD stimulants and stimulant alternatives in pediatric primary care. This is a follow-up to the first webinar that was focused predominantly on diagnosis and introductory use of stimulants. If you have further questions about stimulants and diagnosis, I would refer you back to the initial webinar. This is to remind us of the many phases of ADHD and that ADHD has been recognized throughout the literature for over a century. Today we're going to talk about switching stimulants, stimulant alternatives, what happens when you have tics in ADHD, and some guidance and anticipatory guidance questions. Since anyone that manages ADHD will realize that many questions come up from parents, and the more adept you can manage them, the better the overall management of ADHD will go. First, we're going to focus on switching stimulants with a case. Johnny is a 13-year-old male with ADHD and no comorbidities. He has responded very well to Adderall XR 30 milligrams. In the summer before 7th grade, his insurance changed and Adderall XR was no longer covered. Mom tells you she has heard good things about Concerta, which was covered with no copay. She has never thought that the medication worked after school. She also has had concerns about 7th grade being, quote, harder due to more homework and having to switch between classes. She hopes that Concerta 36 will work longer in the day than Adderall XR. I'm certain this is a scenario many of you that manage ADHD have actually seen. To cover something, again, that are from the initial webinar that I think is a very important part of doing ADHD treatment, is just like any other medical condition, you need to start with your diagnostic theory. So this is a child that we've already diagnosed with ADHD, but it's always important to go back to think about if anything else in the environment, developmental context, or a comorbidity has begun to occur since the developmental context, meaning what's happening in their lives, directly interacts with the ADHD, and also comorbidity is the rule with ADHD, not uncommonly seen. Once you have the diagnosis, which I call diagnostic theory, you then focus on treatment targets, intervention, and monitoring treatment response. These 4 steps are very important as they allow you to monitor what happens, and if things go awry, will allow you to think about where to move forward. So in terms of Johnny and the 4 steps, his diagnostic theory remains ADHD, as there's no evidence of any diagnosis other than that. You could get evidence for other diagnoses by using Vanderbilt's, if there's any suggestion of anxiety, using SCARES, or doing a diagnostic interview. You review his treatment targets from the last session, and it was improved performance during the day and after school. You note that these targets were actually at the beginning of 6th grade, and he did quite well with them. As Mom is concerned now about homework after school and the fact that Adderall's never worked in the afternoon, you decide on an intervention. Change stimulant to longer-acting medication. So, and as Concerta does act longer than Adderall, you believe that that's a reasonable response. And note that the treatment targets can remain the same, improved performance during the day and after school, although now we're going to focus on after school since he has done quite well during school in the past. And you monitor the treatment response by getting Vanderbilt's 2 to 4 weeks after school starts. Johnny continued. This would be late September, early October. Mom and Johnny come in today for a follow-up stating that 7th grade has been even worse than they anticipated, and they want to switch back to Adderall XR30 from Concerta 36 that was started over the summer. I've seen this scenario quite frequently, and in fact, often parents will automatically switch back to whatever medicine if they had some left at home. What happened, and what will you do next? So, what happened with Johnny? I think it's easy to make changes over the phone for ADHD, but it's most important to bring kids in with their families to help understand what's going on. Although this slide was not supposed to originally come up this way, I think it's actually not bad to start with help with school/schoolwork. Oftentimes in kids with ADHD, at 6th, 7th, or 8th grade, the school starts requiring more homework and more of children sort of having their own self-motivation, which kids with ADHD very much struggle with and things they don't enjoy. So even though ADHD is the primary diagnosis, in fact, because it's the primary diagnosis, thinking first about whether this child needs more help with their school and schoolwork now that they're in a different situation is really important. And that's part of the developmental context. And you go back to that slide that I had earlier about thinking about developmental context. So what is the environment? And you think about what are the requirements of 7th grade. As an aside, I often see parents, whoever was the primary parent helping with medication or helping with homework, often getting burnt out around 7th, 8th, or 9th grade. And it's not an uncommon recommendation that I will make saying, could you think about having the other parent do some homework with the child. Not all families can make that work, but the ones that can see some very positive impact. So in terms of treatment recommendations, we're first thinking about the developmental context of whether there's anything we need to do for the child to help with their ADHD. Then we take a look at the medication. So Concerta 36 milligrams is not equivalent to Adderall XR30. Adderall XR30 is actually equivalent to at least Concerta 54 milligrams and maybe even 72 milligrams or higher. This is a short form here. Adderall XR 10 milligrams is equal to Adderall 5 milligrams twice a day. The total is 10. And 10 milligrams of Adderall is equal to Ritalin 20 milligrams 3 times a day. That is a short form. People that haven't done switching, I don't expect to be able to use short forms, and I would expect you instead to use a longer version. So, converting between stimulants. This may look complex, but it's actually 3 simple steps. I would recommend practicing this when kids come in with stimulants. We also may be posting on the Children's Tip site some conversions for people to do if they want to practice on their own. So estimate the total daily dose of whatever stimulant they were on. Now, methylphenidate's relationship to, and you need to know methylphenidate's relationship to amphetamine in terms of daily dose, which are enantiomers. So for those of you who, chemistry is a long time ago, enantiomers, every molecule has 2 sides, the right and the left side, to take you back to organic chem. And if a medicine is an enantiomer, it only has 1 side, and it's been designed that way to make it bind more strongly to the receptor. If it's an enantiomer, it's going to be half the dose of what it was at the enantiomer, and I'll show you this on the next slide. to decide how far apart you think the medicine should be given by length of action. Short, and I separate stimulants into short, longer short, intermediate, and long. That may seem a bit strange, and if you look on things that are written by people that have done research on this, they tend to separate them by short and long. You'll see some articles written by short, intermediate, and long, but the fact of the matter is that really it breaks down more like 4 instead of 3 types. And then you need to figure out how long they're actually working for the child. Finally, once you have an idea about the total daily dose and how far apart you think the medicine should be given, you should convert to the long-acting dose and break up the dose throughout the day based on how long you think they ask, and adjust for the medicines that don't follow the rules. So here is another thing to remember about medicine. So the first thing I said is total daily doses. So Adderall is equal to half of a methylphenidate dose. For example, methylphenidate 10 milligrams twice a day is equal to a total of methylphenidate 20 milligrams a day. So methylphenidate 20 milligrams a day converts to a total of, I'm sorry, there's an error there. That should say Adderall 10 milligrams a day. So let's do this again. Methylphenidate 10 milligrams twice a day is equal to methylphenidate 20 milligrams a day total. And then methylphenidate 20 milligrams a day converts to a total of Adderall 10 milligrams a day, remembering that Adderall is half of the methylphenidate dose. And then the enantiomers, so Focalin, which is dexmethylphenidate, that's an enantiomer. Remember, that's then a methylphenidate, but that's also half the dose. So Ritalin 10 milligrams a day, twice a day, is equal to a total daily dose of Ritalin 20 milligrams a day. Ritalin 20 milligrams a day is equal to Focalin, dexmethylphenidate, which is an enantiomer, 10 milligrams a day. These are all short-acting medicines that we're speaking of here. So this is a table that gives you methylphenidate versus amphetamine medicines that is up to date except for one medicine that was approved 3 weeks ago but is not on the market yet. So it was approved at the beginning of June, and I don't have enough information to include it yet. So Focalin XR have 1 star before them, so that's the enantiomer of methylphenidate. And then I also put 2 stars before Adzenz and Vyvanse. Those are, they have a unique rule, and you cannot use what I just told you with them. So you'll see that the short actings on the left-hand side, Ritalin and Methylin, are 4 hours. Longer short actings can go 4 to 6. That's Adderall, Avicchio, which is essentially just Adderall in a different form, Zenzetti, also Adderall in a different form, and Procentra, which I rarely use. And I actually rarely use Avicchio or Zenzetti because they're currently not covered very often, but they will be in the future. Intermediate acting is Metadate CD, which is 6 to 8 hours. And I think that's very important to use because I see this used to think about in terms of intermediate acting. It's frequently used in pediatric primary care. It was initially advertised as being long-acting. Unfortunately, long-acting means 6 to 8, and that actually doesn't even cover an entire day of school for a full-day child. And then long-acting is 10 to 12 hours, which is your Adderalls, Quilivants, Concerta, Adzenz, and Vyvanse. So if you put it all together, this can give you an idea of what medicines are equivalent to other medicines. I still recommend that you go through the through the 3 steps that I gave you earlier, but this gives you an idea of what's similar to different medicines. And you'll see here that, if I can pull this correctly here, that Adderall XR 30 is equivalent to 54 to 72 of Adderall of Concerta, which was the case we had. Take this off the screen. And there's the stimulants all together with length of action on the left-hand side, as well as which one's an enantiomer and which ones have a unique equivalency rule. So to tell you again in a different form here, methylphenidate 1 milligram is roughly equivalent to 0.5 amphetamine salt, dextroamphetamine, or dexmethylphenidate. Again, start with the same total daily dose and titrate up for effect. Switching from methylphenidate to Adderall, start with 1/2 the total dose and adjust based on the effect and adverse effects. And methylphenidate 8 milligrams a day is roughly equivalent, or Concerta 18 milligrams a day is roughly equivalent to methylphenidate 15 milligrams a day. I put that in there so you realize that Concerta 18 is not quite methylphenidate, so you might need to push it up a little bit higher. And there's the chart again. So that completes the discussion of stimulants. Now we're going to talk about stimulant alternatives and how to manage things that might be construed as side effects and what to go to next when stimulants aren't quite doing the job for you. To remind you again, there's two broad classes of ADHD medicines. There's the stimulants and the non-stimulants. And it's very important to recognize that stimulants are by far the most effective medicine for ADHD, probably have the largest effect size of any medicine in all of medicine for the core features of ADHD. So you should start with stimulants for most children with simple ADHD, even with complicated ADHD, with ODD, or even anxiety. But when stimulants don't quite work, it's often when we have side effects or comorbidities, and that's when I go to stimulants. I do still start, or non-stimulant alternatives. I do start with stimulants, though, for almost all children that I see and adolescents. So here are the stimulant alternatives, / you might also hear them called adjuncts, because they're often used adjunctively. There are alpha-2 agonists, short-acting and long-acting. The short-acting are clonidine and guanfacine, which many of you may have been around for a long time, and Catapress has more uses than just ADHD. And then the long-acting, clonidine ER, Catfe, and guanfacine ER, Intuniv. These short-acting and long-acting really are different in their dosing, so it's very important to know whether you're on guanfacine ER or guanfacine, or clonidine ER or clonidine. And then atomoxetine, Strattera, and bupropion. I will not be talking about bupropion today because I really consider it a third or even fourth line medicine. And if you can really use an alpha-2 agonist, a stimulant, and a Strattera well, you probably rarely, if ever, need to go to Wellbutrin in the pediatric population. So alpha-2 agonists. The claims are that these work in the prefrontal cortex for ADHD, and that's where a lot of the action is for ADHD in terms of planning, concentration, and thinking ahead, basically. They also work in the brainstem to decrease sympathetic activity, and this is why they decrease blood pressure. The side effects are largely from decreasing the sympathetic signaling, so you could see some dry mouth, some sedation, and hypotension. Oftentimes the dry mouth and sedation wanes over time, and we frankly see hypotension a lot less in children than in adults, but I do monitor blood pressure at every single session to assure that I'm not getting hypotension with these medicines. Frankly, they're not often used as ADHD monotherapy, but they're really often used as an adjunct. And they take weeks to see the full effect, although often you'll see some effect in the first few days of a adequate dose. So alpha-2 agonists, dosage, treatment, and side effects. So they're useful for residual hyperactivity if a kid can't tolerate a higher dose of medicine or they're already at the max. Impulsivity, they actually have an indication for impulsive aggression, which is why you might see them used as individual non-adjunctive in kids with just aggression. They can be useful for insomnia, although you have to be careful of that because the insomnia effects may wane over time. They're useful for treatment of emergent tics and aggression. You need to do a routine physical exam and vital signs prior to initiation. And contraindications are cardiac, CAD, impaired liver or renal functions. Side effects, for kids that take an alpha-2 agonist every day for weeks or months and stop, they could potentially have rebound hypertension or tachycardia, although also we see this less frequently in kids than in adults. Hypotension, sedation, dizziness, constipation, headache, and fatigue. And oftentimes I start with an HS dose and titrate to the morning after they've adjusted to the sedation. There's some limited data for the use only at HS, improving impulsivity and aggression. So you may see some kids only on an HS dose of an alpha-2 agonist because they're getting some benefit. Even though these infect the cardiac system, you do not need an ECG routinely, and you should monitor their blood pressure. So alpha-2 agonist pros and cons. Clonidine and guanfacine are the two that we use. Catapres and Catve, Tenex, and Intuitive are the other words you'll see. The pros, they're moderately effective, and as I said before, these are the things they can help for. The cons are the side effects, quite frankly. And I want to highlight one thing there. There was a small report over 10 years ago now, in the early 2000s, that showed sudden death in combination with stimulants. That's never been replicated, but because there is a report out there, we do need to put that up there. I do not tell people that there's one report of this, but I think if you're going to prescribe something, you should know that there was one report that was not at all a controlled study. It wasn't a study at all, actually. So, very specifics on alpha-2 agonists. Guanfacine or Tenex. Here's the dosing, and that's how you start the medicine. Then you can increase by 0.5 milligrams BID to TID for a total of 2 milligrams if they're less than 40. Sorry, that should say kilograms. And 3 milligrams if they're less than 45 kilograms. 4 milligrams if they're greater than 45 kilograms. Sorry about that error. So these have evidence of benefit in treatment of ADHD in children with comorbid tics and benefit in adults with ADHD comparable to dexedrine. So they did do a study of ADHD. This was nowhere near as good as the study of ADHD studies in children. Note the N is only 17. So even though there's one study showing it's comparable to a stimulant, I don't think anyone in psychiatry or pediatrics that does a lot of ADHD would think that guanfacine has a similar efficacy to stimulants even in adults. So long-acting alpha-2 agonists, guanfacine ER and Intuitive. So this has been studied in the range of 1 milligram to 7 milligrams, although you'll see few kids over 5 milligrams, especially in the under 12 range. That 0.05 to 0.12 milligrams per kilogram is a target dose. Again, see that there's not much data over 4, which is why you'll see less kids over that dose. And then you will see some people push these medicines over 7 milligrams, but there's just not that much data, and I certainly wouldn't do it on anyone under 13. So this medicine is very different than just straight Intuitive. And it can be confusing because in the charts, it says guanfacine, and if you have your chart set the wrong way, you may not see the ER. So you really need to look whether it's guanfacine or guanfacine ER. Regular guanfacine comes in, you can cut in half, essentially. Guanfacine ER, you do not want to cut it in half for a variety of reasons. And it only comes in 1 milligram doses. So in some ways, the dosing is much easier than just guanfacine, regular acting, because that you can use 2 to 3 times a day. This is supposedly effective all day long with one pill. And I generally do not use this more than once a day. So again, do not crush, chew, or break tablets before swallowing. It will directly impact how it's absorbed and how it works. Do not administer with high-fat meals. I think that's, although that's in the recommendations, I think that's less concerning for this, as opposed to not crushing or chewing. But oftentimes I don't give this one with meals so that I don't have to worry about that. And do not substitute with short-acting guanfacine 1-to-1. They have completely different pharmacokinetic profiles. So whereas with the stimulants, I talked about how to switch and figure out what's equivalent, with this, you stop the other medicine, and then you start guanfacine ER. So if someone was on short-acting guanfacine and you're trying to switch to the extended release, you start with 1 milligram after you've stopped the short-acting, and then you can increase every 3 to 7 days up to at least 4 or 5, and I mean I would hold until at before, the biggest thing you need to be concerned about is the sedation effect as you escalate. So oftentimes in primary care we go slower than the 3 to 7 days, because if kids get sedated, parents are going to stop medicine. Oftentimes I escalate only weekly, and I have the parents give me a call to tell me how they're doing. There is some data suggesting, it's minimal, but it is there, suggesting that one nighttime dose of these longer-acting medicines could have an effect throughout the next day. So it is possible you could start a nighttime dose and that could be enough. But many kids, we do need to move them more to the morning. And in terms of the do discontinue with a taper, 1 milligram every 3 to 7 days to avoid rebound hypertension. So another alpha-2 agonist, Catapress. And this is clonidine. This you also start at bedtime. This is very sedating when it first starts, less sedating over time, although some kids remain having some sedation. What I wouldn't do with this medicine is continue to escalate it to get more for sleep. I don't usually escalate above 0.2, rarely above 0.3, but if families think they're using this to initiate sleep, they may go up to 0.4 or 0.5. I do not recommend that just to escalate for sleep. Again, often only given at bedtime because of the sedative effects. It's been shown to be beneficial for Tourette's, beneficial in kids with comorbid mental retardation. That's the old term for intellectual disability. And there was a large meta-analysis done that shows that it's not as effective as stimulants, which is not surprising. The long-acting alpha-2 agonist is Capve, and this you increase by 0.1 milligram every week. Again, you don't substitute one-to-one with other clonidine products, just like you don't for Intuniv. The side effect profile, very similar to all the other alpha-2 agonists, and also could lower blood pressure and heart rate, although we don't see that as much in children. And again, because it's a long-acting, it should not be crushed, chewed, or broken before swallowing. And also taper this, just because of the risk of rebound hypertension. So Strattera. I think at first there was a lot of excitement about Strattera. Anyone who works with ADHD knows that there's a lot of worry about starting kids on stimulants, even though they're very effective and have very few side effects. So Strattera was released as a non-stimulant alternative. When it was released, the company actually wanted it to be an antidepressant, but they could not get enough data for it to be approved as an antidepressant. So it is only a treatment for ADHD. That being said, its chemical structure is similar to an antidepressant, which is important to remember as you're using it, and will come up again. So Strattera is completely different than any of the medicines we've talked about so far for ADHD. You only usually do once daily dosing. You may see some psychiatrists doing twice daily dosing because of concerns about how kids metabolize the medicine, but I don't think as a primary care doctor I would get to that level, and the data is not that strong actually. So it's not like a stimulant where you take the medicine and you immediately see the action. This is, because its chemical structure is similar to the chemical structure of an SSRI or an antidepressant, it will take 2 to 4 weeks to see the full incidence, see the full effect. The incidence of insomnia was actually comparable to placebo for kids and adolescents, although I have seen some kids get tired on this. It's not contraindicated in patients with tics and anxiety, and it's a non-controlled substance. And the other thing about Strattera, and this comes directly actually from the marketing material, is it may improve some measure of functional outcome, not just core symptoms of ADHD. So stimulants are the best medicine for the core symptoms of ADHD, those 9 hyperactive and impulsive and 9 inattentive symptoms. Strattera, because of its properties of being similar to an antidepressant, may help with anxiety. I would not use it as an anxiety treatment. Parents will read about it. Smart parents will get online and read about it and come in and say, this is a perfect choice for my kid with a combination of anxiety and ADHD. I would not use it as a primary treatment for anxiety. And the way I describe that to families is I say the gold standard for ADHD is a stimulant. The gold standard for anxiety in terms of medicine is an SSRI. Both of those in combination with therapy. But Strattera is a gold standard for neither ADHD or anxiety, so you're essentially starting, if you would start with Strattera, with a second-line medicine for each condition. And I put some dosing information on the bottom. What the packet recommended is that you actually do 10 milligrams for 4 days and then double to 20. And the max is 1.4 mg per kg, or 100 milligrams. So to get more into the side effects. Even though this is not a stimulant, it's interesting to note that it does decrease appetite. It's less frequent than the stimulants, but it definitely has. And in fact, there was a 2 to 4 pound weight loss in the first 3 months that was not unusual in kids receiving this medicine. And then they'd resume their normal growth curve. There can be some dizziness, dyspepsia. The dyspepsia is probably related to the serotonergic effect, perhaps even the dizziness as well. Although they claim there's less sedation, I've definitely seen that as a potential side effect, and you do monitor the blood pressure and heart rate. So even though these are not stimulants, they have some of the stimulant side effect profile. And then adults, you may more frequently see anticholinergic side effects, sexual side effects, insomnia, nausea, and the blood pressure and heart rate changes. There is a very rare side effect of liver toxicity that as a physician you should be aware of. And because the chemical structure of this medicine is similar to an SSRI or an antidepressant, as we spoke of before, this medicine does have the black box warning for suicidality. So if you're concerned about the black box warning, you should be talking about that when you consent medicine for Strattera. So when do I consider Strattera? If a kid's had a history of adverse effects with stimulants, if they have comorbid anxiety, depression, tics, enuresis, or Tourette's, if they're having trouble with 24-hour symptom relief. Now, I have to say, I first try to maximize their stimulants and their non-stimulants before I go to, and their alpha-2s before I go to Strattera. But there are some kids who I have on stimulants and I have on Strattera because they need more management during the evening to be able to drive. Or kids that when you give an afternoon stimulant, they can't sleep at night, and then you're chasing inattention during the day. Because you can give Strattera at any time during the day, because it's not as likely to cause insomnia. Strattera is definitely something that I will use to, and I have to say most frequently to augment stimulants, although I do have several children on Strattera alone. Also, if there's severe stimulant rebound, so if there are some children that no matter what you do when you give them a stimulant, if you make sure they eat, if you make sure they sleep enough, if you give them an alpha-2 in the afternoon, they're so irritable in the afternoon. They don't have anxiety or depression, or they don't have depression, and they just can't function because of their stimulant rebound. It's rare, but it does happen, and since pediatricians see a lot of ADHD, they are going to see this. And with severe stimulant rebound, Strattera, either in conjunction with a stimulant or alone, can fix that problem. So that's the scenario when I use Strattera. The other important scenarios, there's a personal or family history of substance abuse. If you're worried about diversion of stimulants, you really don't want to prescribe stimulants from a pediatric primary care perspective. There is data for using stimulants when adolescents have substance abuse problems, and it's not in fact contraindicated, but you need a lot of support to do that in a way that you feel comfortable that you're helping the child. And very few primary care sites, I would say very few psychiatric sites, have the supports in place to do the monitoring necessary to prescribe a stimulant for a kid with a substance use problem. So if you're concerned about substance abuse or use, I would use Strattera over a stimulant. For truth in advertising, if I'm concerned about substance abuse, a disorder, which is rare in pediatrics, thank goodness, I would get them to treatment for that condition because it's so likely to exacerbate ADHD and make it hard for you to know what to monitor. As pot is becoming increasingly utilized across the U.S. and in Pennsylvania, if kids are using pot at all, I would be leery to treat ADHD because it affects the course of the ADHD, and you'll have trouble knowing what to treat. And also, if there's concern about insomnia or appetite suppression. Although, as an aside, and I believe this is in the first webinar, if someone has appetite suppression, I would use Periactin to try to improve their appetite before I would switch to Strattera. But concern about insomnia could be a reasonable reason to use Strattera. So, just to remind you, we always think about the developmental context and come up with a diagnostic theory, decide whether ADHD is still the primary diagnosis before we move into treatment. And we always think about the theory, the treatment target, the intervention, and we monitor treatment response. There's even some more recent data showing that the more closely you monitor response, the better the kids will do. And clearly that was shown in all of the studies the well-controlled studies that have been done on ADHD treatment. And this is, for those of you who aren't sure about the differential for ADHD, this is from the first webinar. I'd suggest you go back, but you always need to think about developmental or learning concerns, emotional or behavioral concerns, and physical or other concerns, and probably in that order. So another case. Rebecca is a 10-year-old girl who's been struggling with ADHD symptoms of inattention for years. She was started on Concerta and is currently taking 36 milligrams a day with improvement in school performance. She's been tolerating the medication well and has been thriving in 5th grade. Rebecca's mother brings her in for a sick visit, noting that for the past 2 weeks, Rebecca has developed asthma and her ADHD is worse. She's been coughing persistently and occasionally shaking her head violently, and the teacher complained about her behavior disrupting class. She has no significant past medical history and no other medicines. Mother is very concerned about these episodes, which do not happen while she sleeps. Rebecca does not report being bothered by these behaviors, which, quote, I just kind of have to do. So, to remind us about our approach to treatment, we think about the diagnosis, and then we work on the treatment targets. And for diagnosis, we think about the developmental context and environment. So, and to remind us of the general differential. So she's in 5th grade, and it doesn't look like there's been any new developmental or learning problems. So at this point, that's easy to rule out, although it's always important to ask the mom if there's any new concerns about learning and considering and see whether there are school interventions. They're denying any avoidance, periods of mood problems, hostile behaviors, or recent trauma. So then I move into thinking whether there are physical/other concerns, and ask again about snoring, awakening, or difficulty with sleep, substance use, even in 5th grade, tics, or other medical or psychiatric conditions. And her description, and I'm going to go back just to, has some things that are consistent with tics. So occasionally shaking her head violently, and I think many people would recognize that as a potential tic. But I just kind of have to do it, feeling compelled to complete a behavior, and that if they don't complete a behavior, their distress builds. That is a common complaint in kids with tics, and it's an important thing to know. So let's go back. So the question is, what's our diagnostic theory? What are our treatment targets? What's our intervention and our treatment response? And it's important to go back to what your original for approaches to treatment were. So her diagnosis was ADHD, and her initial treatment target was improve attention at school and decrease hypermotoric behavior. When I look at those treatment targets, I think they're clearly ADHD targets, but now knowing that she might have a tic, I go back and think, could some of those have inadvertently been tic behaviors? Now, Tourette's and ADHD have a high comorbidity, so it's not like you have to have only one or the other, but it's important to start thinking about which could be which. And the intervention we used was Concerta. Stimulants are an appropriate intervention for kids with ADHD and tics, but they could potentially exacerbate tics. So when you gave her that intervention, you did follow-ups, and she actually improved her attention and her school performance improved. So when I go back, I think it looks like the stimulant helped her attention. But I'm not sure about hypermotoric behaviors, because you can be hypermotoric and still do well in school. So what happened to Rebecca? And I see two options. One is she developed tics. The other is she's always had tics, and we just didn't recognize them until we exacerbated them a little bit with stimulants. Since tics their onset is commonly in the same age range as ADHD starts to become impairing, it is not uncommon for these to show up at the same time. So I am careful to make sure I ask about tics before I start stimulants. And I don't say, does your child have tics, because parents may say no when they really do. I ask very specifically, do they clear their throat? Do they have more sniffles than other kids? Do they have any motor behaviors that they repeat? And so I get that documented before I've started a stimulant. So again, ADHD and tic disorders are related. The brain structures actually overlap, and they overlap pharmacologically. Kids with ADHD have higher rates of tics. Kids with tic disorders have higher rates of ADHD. The ACAP, which is the Child and Adolescent Psychiatry Organization, recommends that if you have ADHD and a tic, treat whichever is the most impairing first. So if a kid has clearly got a tic and they can't concentrate because they're completing their tic, you want to treat the tic first. And that would be a whole different strategy, although some of the medicines overlap. If the tics are minor, which even if this child did have tics before you started medicine, they were probably minor because they didn't get identified, then it is reasonable to start with a ADHD medicine, even a stimulant. So my recommendations, beware that treatment targets actually line up with the diagnosis you're treating first. So like I said, I always go back and say, well, is that thing we thought ADHD, was that really a tic? And Vanderbilts can be quite useful for this. So just to remind you, a positive score on a Vanderbilt is 2 or 3 in any of these. And 1 through 9 is the inattentive, and 10 through 18 is the hyperactive. And on the screen, it always tells you how to score it in case you forgot that day. And there is some room to give feedback about performance, both academically and in the classroom. Although this area, these 36 through 43, are probably not as supported by literature as having validity, it's still useful information. So tic disorders. As I said before, these things are related, and whether or not stimulants actually cause tics and cause long-term tics is a debate in the field. In fact, multiple studies have shown that they don't increase tics, but then there are also a number of studies showing that some people initiating stimulants may develop a transient tic that goes away. What we tend to say is that stimulants may cause or unmask tics. Most likely those that get tics had some sort of tic behavior prior, as the physiology overlaps so much. And the treatment, if someone gets worsening tics on stimulants, is altering the stimulant dose, meaning decreasing it, discontinuing the stimulant if it's unbearable or the child can't manage it or the family feels that it's really interfering. Change the stimulant. Sometimes the child will get tics on one stimulant and not another. You can use an alpha-2 agonist either as an adjunct to have them use a lower dose of stimulant or alone. You can also use antipsychotics, CBT, and Strattera. So what to do for Rebecca? So I'm going to start on the right-hand side here. Get more information and talk to the family in the office. Just as we talked before, review the initial diagnosis and treatment targets. What did they mean by hyperactive behavior? Is inattention really ADHD? Review the intervention and response, and how impairing is the coughing and shaking, and reconsider diagnostic theory. Again, did they have throat clearing in the past? Did they have any of these in the past? So for her diagnosis was ADHD on the left-hand side. Her initial treatment target was to improve attention at school and decrease hyperactive behavior. And what had happened is you'd increase the Concerta to 54, and the Vanderbilt showed improved attention, and school performance has also improved. So she's still showing some improvement with the stimulant, even though she has this new behavior. So when I reviewed the initial diagnosis and treatment targets, I saw that she has a lot more inattention than hyperactivity. And again, I'm wondering, what do they mean by hyperactive behavior? Some teachers are very attuned to this, some less so. So is fidgeting really fidgeting, or was fidgeting a tic? And I outright talk to parents about this so they can get themselves educated, and I send them to the online organizations for tics to read more about it so they can understand it. So for her, I see a number of symptoms here that are inattention that got better with stimulants. And then I see a number of symptoms, fidgeting, on the go, or is driven by a motor, of hyperactivity. Certainly fidgeting or on the go could have been a tic. So I would watch for those to make sure those don't get worse with the stimulant. But I see so many inattentive symptoms that I would say that I still think that she has ADHD, especially since she had improvement with medicine. But now it's important, if you have a way in your chart, to keep Vanderbilt so you can compare to the future, so you can see if some of these get worse with stimulants. And to remind you that these are the positive ones. So what happened to Rebecca? Oh, this is a repeat slide, sorry. So you think she has tics. The question becomes, how impairing are the tics? So oftentimes when a kid develops a new motor behavior, some families and some schools, especially if they think, for example, in this child, the school actually thought she was having a seizure, they began focusing on it and really made it into worse than it really was. She probably had a cold at the same time as well. So it's important when a kid develops tics to really have a discussion with the family and the kid about whether or not they're impairing. If they had it before and it's not changed, or they had it and it's only slightly worse and it's not impairing and the medicine is really helping, I've had families clearly decide to continue their stimulants. There's others where they've, even though they're not that impairing, the families and the child have said they wanted to stop. You also need to look at that point for any other potential tics and look for past tics. So, as I said before, with Rebecca now, for the next treatment targets, I'd like to clarify them. The hypermotoric behavior could have been tics to begin with, so you can't treat that with stimulants. So it's not really a good treatment target, although you may want to look at it for the potential side effect. It could be a treatment target if you're doing an evidence-based intervention for tics. So if you think the hypermotoric behavior was due to the tic, was due to her movement that was a tic, there are interventions just for tics, not just medicine, but therapeutic interventions, and then you would make that a treatment target. And is inattention a symptom of ADHD or something else? And our working treatment plan was that the inattention was directly a symptom of ADHD because it was responding so well to stimulants. You review the diagnosis, and there are the things that make me think it's ADHD. Trouble completing 3-step commands, head in the clouds, room's a complete mess, and mom says she's just like dad who's really done well on a stimulant. Don't forget about anxiety and transient tic. So notice some of these things that I used for review her diagnosis aren't in the Vanderbilts. They're just from a discussion and from knowing the families and kids, which I think, you know, pediatricians probably do a better job at than than psychiatrists. So the Vanderbilt's not the beginning and end of your diagnosis. Really how you know the family and getting more information about things that could be ADHD and not tics help you with a differential, just like they do in the rest of medicine. So another case. Curtis is an 8-year-old boy with ADHD and ODD. He has home-based therapy. There is no history of trauma. He does not have any anxiety, depression, conduct disorder, or other medical condition. He has friends. Teachers express frustration with him because he seems to argue a lot and purposely defy rules. Mom brought him in today, stating that school is going much better this year now that he's taking Adderall XR20 for 6 months, and that he is angry, irritable, postures aggressively to her in the afternoons. He is even irritable in the afternoon on the weekends when there's no schoolwork. So here's a kid doing well in school who's very irritable after school. And it doesn't look like he's excessively having impulsive aggression, but it sounds like he's posturing to mom. So mom may be a bit scared of him, that even in 8-year-olds that can happen. So we'll go back to our diagnostic theory and approach to treatment. So in terms of diagnostic theory, his diagnosis is ADHD and ODD, and we need to think about what his treatment targets are. So what should you do about Kurt's irritability? Review diagnosis and treatment targets. Vanderbilt's confirmed that school is going really well. Teachers have made accommodations to reduce the work burden, so this kid's in a really good position in terms of accommodations. And mom says these have helped. I think through the differential, and with him, I don't have any concerns other than that he does have ODD, and we need to think about whether or not he needs a non-pharmacologic intervention for his ODD. But the fact that he's doing well in school is reassuring. So my diagnostic theory for Curtis, he still has ADHD, and afternoon irritability with mom is a component of ADHD, either a side effect of the medicine or just a component of ADHD. We will assume that I've ruled out side effects of the medicine before, and that we've worked on making sure he eats during the day. So new treatment target, I'm going to focus on after school, is starting homework without having an aggressive behavior towards mom 3 out of 5 days of the week instead of 0 out of the 5 days of the week. And remember, he's got a home-based team, so they could clarify this goal. Now, it doesn't take very long to come up with a specific target. In fact, I think many doctors do this naturally. But in this situation where you can clarify the frequency, it can really help you to measure the impact of your intervention. Because aggressive behaviors are frustrating, and parents may come in and say they're still there when they've actually decreased in frequency. So I'm going to treat ADHD in the afternoon with a stimulant or an alpha agonist. And we chose with him to choose an alpha agonist because of a history of mom being concerned about him not eating enough and not sleeping well with an afternoon stimulant in the past. So 10x.5 could start at bedtime for at least 3 days so he adapts to the sedation. And once he's adapted, I give the medicine a half hour before he starts to develop afternoon symptoms. So a few more things about guidance and anticipatory guidance, and then we'll be done with this webinar. So I've had a lot of families come in complaining about their child's hygiene, specifically their girls. And it's a common complaint, especially from mothers, although I have had it from fathers too. Many children with ADHD don't pay a lot of attention to their hygiene. It could be a combination of factors related to inattention, also related to sort of them being slow to rise in the morning. I actually warn mothers about this and warn them about the importance of scaffolding the skill as they would scaffold any other skills, meaning not expect them to be as attuned to their hygiene as their other sisters or even brothers, but to take a look at the skill of being attuned to hygiene, meaning their hair, their clothes, or even showering, break it down into pieces and help them develop each individual skill. Should I consider an afternoon dose of stimulant? I'd say yes, especially for adolescents who have more afternoon schoolwork. If the adolescent will be driving, there's a lot of data now showing increased safety if a medicine like a stimulant is in the afternoon. Some other evidence for non-stimulant alternatives too. Also, if the adolescent will be working in the evening. Be aware of the burnout effect. I alluded to this early. This is a tendency of parents or families to feel that the child is, quote, ready to take on responsibility, and as a result, they give all the responsibility to the child at once. I've seen this so many times, I couldn't even count it, that mother or father have functioned highly for a kid for years. They get frustrated with the adolescent for a variety of different reasons and say that they should be ready and say it's all on you now. I think it's a bi-directional thing, as children also, adolescents also will say they want to take complete control. But this effect can really make it look like like interventions aren't working when they have been working, and you just need to continue to scaffold, meaning slowly add on responsibility. So plan. Let the parents know that they'll need to have some responsibility for monitoring their child's medication through adolescence. Maybe change the monitoring and support and tell them support should go down in baby steps. Consider a switching parent who does homework. I also warn parents about that when adolescent comes, that their kid is going to need support a little longer than other children or adolescents. My 13-year-old has grown a lot, and her inattention is back. So this is a common complaint. Should the medication be increased because of her change in weight? The answer is no. There's absolutely no evidence showing that the dose of medicine needed for effectiveness is related to weight. And there is some reason to believe that as a child reaches adolescence and has more responsibility, they may need a higher dose. It has nothing to do with weight. It may just have to do with the more responsibility and the more use of prefrontal cortex control. But again, I remind families that it's not due to weight. And then, will you send me a higher dose of medicine? I think this happens a lot, and I think this happens a lot to pediatricians who are busy, family practice doctors who are busy. Whenever families call asking for a higher dose of medicine, I take a look at, has an evaluation been done that year suggestive of ADHD? And by evaluation, it could simply be Vanderbilt's or seeing them in the office. If yes, then you can increase the medicine. Or no, get Vanderbilt's, consider PHQs to make sure there's no depression or anxiety or scared, which also help with anxiety. But be wary of just doing multiple medicine increases over the phone because you could get stuck in a position where you're not really sure what's going on, and that's not good for anyone. My 14-year-old is now fighting me each time we sit down to do homework. That sounds familiar. That's Curtis that we talked about earlier. The other thing I think about is pairing up with a responsible friend and considering tutoring, which a short period of tutoring can make a big difference for some families. My child doesn't like the way the medication makes her feel. This is very common, especially in adolescence. So at that point, I really like to talk to the adolescent alone about what the positives are about medicine and capitalize on them. A lot of times the parents will be telling the kids what are positive about them, but the kids may or may not believe them. So I start this early. I start this before adolescence, and I have the kids tell me what they think is positive and what they don't like about medicine, so we're prepared for what might happen when the child hits adolescence. So finally, late high school graduation. I don't think my child is ready for college, military, etc., as she has trouble taking care of everyday needs. Again, remember the importance of small steps. Start the steps early. Start with a job early. It's reasonable to consider a year off between high school and the next step, but the kid needs to get a job, learn to manage bills, and pay for housing. Scaffolding is really important, meaning you have to give them additional responsibility as they age, even if you think they're not ready. It doesn't mean they're ready for necessarily the military or college, but you do need to give them increasing responsibility as they age. And if they're going to college, consider getting support in college, studying support, therapy support. There are colleges that do better with this than others. Put the child in charge of finding out what's available on campus. Seriously consider whether or not they can manage stimulants on campus. Maybe that's a time to go to a non-stimulant alternative. Make sure there's a way to secure the medicines. Talk about the importance of sleep, eating, etc., and let them know that sharing medicine is illegal. And the last little step about melatonin, it has been shown to be useful for delayed sleep, also useful for ADHD and sleep problems, and there's the way to use melatonin. Notice that I don't ever use over 6. I actually rarely use over 3. And it can be used from late evening to dinner. and a half hour before sleep, either way. So to remind you about the basics, we always want a treatment theory, and then targets, intervention, and monitor treatment response, and the take-home points of both of these webinars. Comorbidity is the rule with ADHD. Inattention alone is not ADHD. In other words, ADHD is never one symptom. If someone comes in complaining of just one symptom, you should seriously consider getting more Vanderbilts. Improved medication management may impact comorbidities. Non-pharmacologic intervention has a vital role. ADHD is a lifelong condition with serious lifelong implications, and a consistent approach with follow-up can make a difference. Thank you very much for participating in this webinar, and I hope you have a good day.